Hello, good afternoon. I'd like to welcome everybody to the ARC Talks webinar series. It's brought to you by the Amyloidosis Research Consortium. My name is Isabel Lusada, and I'm the CEO and founder of the Amyloidosis Research Consortium, also known as ARC, and also an AL amyloidosis patient. Just by way of background, the mission of ARC, which was founded in 2015, is to accelerate the development and access to new and innovative treatments for systemic amyloidosis and improve quality of life for patients. We're a consortium model where we bring together all the different stakeholders that are working in the field to partner to really accelerate and advance programs. Our main areas of focus on improving the speed and accuracy of diagnosis, increasing understanding of the biology of the disease, accelerating regulatory approval, and also reimbursement of treatments for patients, and also enhancing care and quality of life for patients and caregivers throughout their journey. And so I'm really thrilled to introduce our speakers for today. I had a stem cell transplant 25 years ago in last February, and I really feel there's so much that would have been helpful to know, and so I'm really thrilled to have our speakers today. So without further ado, I'd love to introduce Dr. Sandy Wong, who is from the University of California in San Francisco, and Teresa Fogaren, who's based at Tufts Medical Center, who works with Dr. Comenzo, who was indeed the physician that gave me my transplant and looked after me, and I was in one of the first cohorts of patients. So I'm delighted to hand over to you both. Dr. Wong.
Thank you so much for the introduction as well, and thank you so much to the ARC for inviting us to speak today. And thank you to all the attendees for coming, and I hope you learned something today about stem cell transplant for this disease. Here are my disclosures. This is a brief outline of the talk. We're going to go through what is systemic AL amyloidosis and how does this disease work. I'm going to give an overview of how transplant works for this disease. And then Terry's going to go through the pre-transplant evaluation and preparation. I will review the hospital course as well as the side effects of stem cell transplant. And then Terry will go through post-transplant care after discharge. So what is systemic AL amyloidosis and how does this disease work? This is a protein deposition disease as well as a cancer, but it's not like what we typically think of as cancer. Sometimes when we think of cancer, we think of a lot of abnormal malignant cells forming tumors or balls that are in the body pressing on organs, etc. But that's not the case for systemic AL amyloidosis. In this disease, the abnormal cells are actually relatively few in number, but it is the toxic protein that it makes that gets people sick. The most common organs involved in amyloidosis include the heart and the kidney. In the heart, it can cause heart failure and abnormal heart rhythms. And heart failure is essentially manifests itself as, for example, a leg swelling here on the bottom right. We see a patient's leg, and there's so much swelling in the leg that you can leave fingerprints in the skin. And this patient here has distended neck veins, which hints that this patient has problems managing volume in his body. In the kidneys, early in the course of disease, patients would spill protein into the urine, and it's not uncommon for patients to say, "Hey doc, my urine looks like beer because it's so foamy." And when the disease progresses, it can result in kidney failure. Amyloidosis can deposit in the gut, in the nerves. It could even cause a bleeding disorder, such as factor X deficiency. And it could also deposit in the soft tissue, leading to hair loss, nail changes. On the right here, you see a patient with an enlarged tongue due to amyloid deposition. And the tongue is so enlarged that it presses against the teeth, which then creates these teeth marks along the sides, edges of the tongue. As you can see here, this is what we call scalloping of the tongue. The amyloid deposits could also form in the small blood vessels around the eyes and the face, and that can lead to bruising around the eyes. And sometimes in severe cases, it could be very prominent, and sometimes we call that quote unquote raccoon eyes because of the darkening around the eyes. But most of the time, the heart and kidneys are the most affected. Unfortunately, because these symptoms mimic a lot of more common diseases, patients with systemic amyloidosis are not diagnosed, unfortunately, until late in the course because it tends to mimic other diseases. So how does this disease work? This disease is diagnosed by a biopsy. It could be a biopsy of the heart or kidneys. In some patients, they get a fat pap biopsy, and that's when you see the amyloid fibrils under the microscope. Here, this gray image here are the fibrils of amyloid that's found. And once amyloidosis, AL amyloidosis is discovered, there's a search then for the factory. What cell in the body, what abnormal cell in the body is responsible for the production of these amyloid deposits? Most of the time, the cellular factory is a plasma cell factory, and sometimes people use the term loosely, myeloma. That's probably in around more than 90% of cases. However, in a small percentage of cases, patients have a low-grade lymphoma as the underlying factory. This factory, if it's myeloma, it sits in the marrow, and it makes these toxic light chains and antibodies here in green, which then deposit in the heart or the kidneys, represented here by, let's say the kidneys is the liver, or the heart are the trees. And essentially, it pollutes these organs and makes them not function well. The goal of treatment is obviously to improve the quality of life for the patient, as well as the quantity of life. And we do that by shutting down this toxic factory so that it will stop making these light chains that are toxic to these organs. And we've got to do that quickly, and we've got to do that completely. If you could think about, with the analogy of a factory that is making toxins that's then polluting the trees and the river, you want to shut that down as quickly and as completely as possible, with the hope that those pollutants will hopefully come out of the trees, come out of the river over time. However, we must do that quickly before there's irreversible damage to the heart and the kidneys. And that's why when we find this disease, time is of the essence, and it's very important that we act quickly to provide effective treatments for patients with this disease. So why do we do a stem cell transplant for AL? There has been a lot of advances over the past 30, 40 years for the treatment of this disease. Back in the 1970s, the melphalan, which is a alkylating agent, this is traditional chemotherapy, combined with prednisone, which is a steroid, was really the first effective treatment against this disease. Now, I say effective, it wasn't very effective, but it produced a hematologic response, which is how well shut down the factory is. When I say hematologic response, I'm really referring to how well shut off that factory is, of around 28%. And unfortunately, in terms of an organs getting better, an organ response was only 20 to 30%. So even though it was our first effective regimen, it wasn't that effective. And then came in the 1990s the advent of autologous stem cell transplant. This was a major improvement in the treatment of this disease and was pioneered in the United States at Boston University and actually spearheaded by Dr. Comenzo, who's the amyloid doctor that Terry works with, and also my former mentor as well. The BU group really pioneered this modality of treatment. As you can see here on the right-hand side, when transplant came around, the hematologic response was 62%, which is a major jump from the MELPRED, which was only 28%. And in terms of an organ response, it was 66%. So that was actually really amazing because we're able to finally achieve some semblance of organ improvement with this treatment. However, obviously not everybody is strong enough to go through a stem cell transplant, and we're going to talk about that a little bit more. And over the years, after stem cell transplant was being used, there have been other agents that's been studied for the treatment of AL with very modest effects on heme response and organ response. But then in 2012 came bortezomib-based therapy in combination with cyclophosphamide, which is essentially belongs to a similar class of, the same class of agents as melphalan, combined with dexamethasone, which is a steroid. This regimen is called CyBorD. And this was exciting because if you look on the right-hand side, in terms of a hematologic response, it looks actually really good. However, over time, we realized that even though the number looks good in terms of the hematologic response, but the organ response wasn't so good, around 17% for cardiac responses and 25% for renal responses. And so for a long time, if patients are transplant eligible, the recommendation is that patients get a stem cell transplant. And for those who are transplant ineligible, then it's CyBorD with the hope that outpatient will be the lucky one that responds in terms of the organs. More recently, daratumumab came on the scene, and this is a drug that is an antibody that uses the patient's own immune system to get rid of these plasma cells. It is directed against a protein on the surface of plasma cells called CD38. And in 2021, this year actually, in combination with CyBorD, this regimen represents the first FDA-approved treatment regimen for systemic AL amyloidosis. So that's all really exciting. But then this also raises the question of where does transplant fit in these treatment armamentarium that we have. And in order to understand this, we'll get into the details of what exactly did the trial show that led to the FDA approval. The trial was called Andromeda, and it was a randomized phase 3 trial randomizing patients to CyBorD versus Dara-CyBorD. And in those that got Dara-CyBorD, around 79% of patients got into a very good partial response or better. And this is how well shut off the factory is. We kind of grade the depth of how well shut down that factory is in terms of a complete response, very good partial response, and the third tier down is a partial response. And as you can see here, 79% of patients in a very good partial response or better, compared to 49% of patients on the CyBorD. So this is a big difference in terms of how well shut down the factory is. And this translated into much better organ responses, because ultimately we want the organs to get better, right? We don't want to just treat a number. We want to make sure that the organs are actually getting better and the patients are feeling better. And if you look at the cardiac response and the renal response, it is almost double that of the CyBorD arm when we use Dara in combination. Now, this trial was really done for patients who did not get a stem cell transplant, or for which a stem cell transplant was not intended. What about stem cell transplant? Modern day. What do we know about it? We know this is a retrospective look from BU, where they looked at their experience for patients who went straight to stem cell transplant. And you can see here, if you add up the VGPRs and the CRs, that percentage is around 74%. So pretty high, very similar to the earlier data. And at 6 months, the renal response was around 52%, and the cardiac response was 42%. And in actually very comparable to the Andromeda trial. Obviously, these are two separate studies. It's very hard to do, cross-study comparisons. They were done one was a retrospective look, and the other one was a prospective trial. It's hard to compare, but this is the data that we have to work on. So, transplant works very well for this disease to this day. But the Dara-CyBorD seems like it may work just as well as a stem cell transplant, though it is early days for Dara-CyBorD. Very commonly, patients will ask me, so how much time am I buying with a stem cell transplant? What's the chances of relapse? And if it does happen, how long would it take? If you look at the BU series, if the patients achieve a complete response, around 32% of patients have a relapse, and the median time to a hematologic relapse is around 4 years, though that range is rather wide. The Mayo paper took all comers in terms of response, and again, around a third of patients had a relapse, and the median time to relapse was a little shorter, around 2 years after transplant. So where does that leave us now, the current day treatment for transplant eligible patients? So the recommendation is that patients start with Dara CyBorD and then be considered for a stem cell transplant if they achieve less than a complete response after 2 to 3 cycles of treatment. And you'll know this rather quickly. The median time to a complete response is around 60 days on the Andromeda trial. So you'll know kind of early whether or not someone is responding appropriately to treatment. Exactly at what time point a patient gets taken to stem cell transplant, and the question of are patients who are in a very good partial response, should they be transplanted? Those are questions that are very specific to the patient and the doctor taking care of that patient. So I would encourage you to discuss with your amyloid doctor what the right approach would be for you if you fall into that category. Now, what is an autologous stem cell transplant? First, we have to understand what stem cells are. Stem cells are seed cells that live in the marrow and then give rise to white cells, red cells, platelets, and these are all components of your immune system as well as your blood system. It used to be called a bone marrow transplant, but technically that term is outdated. It came because in the old days, we used to put a needle directly into the bone to pull the stem cells out. Luckily, we don't have to do that anymore for this type of disease. The other thing that we must understand is melphalan. We talked about melphalan earlier. Melphalan by mouth, we know is effective against this disease, but melphalan given IV at high doses is very effective against plasma cells. However, it is toxic to the bone marrow, hair follicles, and the gut. And the high-dose melphalan will wipe away the plasma cells, but it would prevent the bone marrow from recovering if we didn't have stem cells. So stem cells to the rescue. The reason why we collect the stem cells ahead of time is that a patient's own pre-collected stem cells rescue the patient from the marrow toxicity that's associated with high-dose melphalan. However, only 25% of newly diagnosed patients are eligible for stem cell transplant. Transplant eligibility varies by center, but I can tell you every center that does these types of transplants very carefully vet the patients to make sure the patients are strong enough to get through one. Generally, patients with very advanced stage cardiac amyloidosis are not eligible. Patients with livers that work well are also not eligible. And patients who are on dialysis are eligible just depending on the center. Those with really poor renal function on the verge of getting dialysis are generally not eligible because there is a small chance of renal function getting worse during the course of stem cell transplant, and we would want to tip the patient into needing a dialysis due to transplant. Also, if you have a severe bleeding disorder from amyloidosis, like we talked about factor X deficiency, that will also render a patient ineligible as well. So it's a very carefully selected group of people that we deem eligible to receive this intensive therapy. Now I'm going to turn this over to Terry, who will go over the pre-transplant evaluation and preparation.
Thanks, Sandy. So I'm going to go over what happens before you actually walk in the room over the next few slides. The first thing you're going to do once it's determined you're going to take that path is to meet with a stem cell coordinator. This person's going to be your best friend for the next few weeks. She's going to help you, guide you through the process, answer all questions, give you the knowledge you need to get in, and then organize and provide you with a schedule to make everything happen. As part of the pre-stem cell transplant workup, we want to evaluate your organs. So you're going to have tests like pulmonary functions for your lungs, echocardiogram and EKG for your heart. We're going to look at your disease and do a bone marrow biopsy. And we also want to make sure your mouth is in the best shape it can be. So we'll have you see your dentist and get an approval from him to move forward. There's a litany of labs that will go along with this process. Once all that is complete, the stem cell coordinator will put a package together and submit it to your insurance. Once approval is obtained, we'll move forward. One thing I like to do is have my patients tour the bone marrow transplant unit. That way you can see the unit and then get a feel for what's actually in the rooms and know what to bring with you. A very important part of this is developing a network for support to guide you, to get you through this process and support you. We'll introduce you to a social worker, and that person will help you with psychological and emotional needs. She'll discuss the healthcare proxy and identify a person that can speak for you should you not be able to tell us what you want. She'll discuss a leave of absence for work, and you should think about getting at least a 6-month leave. She'll also mention a chaplain, which some people find very helpful as an added support. It's important to also identify a caregiver, an adult, family member, or friend who can be your right-hand man. This person is going to help you with daily needs that have to be taken care of so that you can put 100% of your focus on your health and your care. They'll do things like drive you to appointments, pay bills, make sure the groceries, the house cleaning, just the everyday daily needs. Another thing to discuss with your transplant team is housing. Many centers require you to live within an hour of the hospital for a period of time post-transplant. And this is a good time to know that and discuss it. Other things to think about are just finances and childcare and pet care when you go in. Now you're closer to getting in, we have approval. Many people ask, will I lose my hair? It's a good question, and unfortunately, yes, you will. But the good news is it will grow back. Think about how you want to proceed with that. Some people decide to cut it before they actually walk in the door, and others wait. It's all your decision. It's also a good time to think about wigs, should you want to go that route. There's different centers or places that your bone marrow coordinator can refer you to. And recently I found out the process might take 2 months. So just think about that when you're planning. People also want to know what to bring in. This is going to be your home away from home for the next couple weeks. Think about personal care items that you prefer your own rather than hospital assigned. You can bring a soft bristled toothbrush, mild soaps, mild creams, but remember they should all be non-scented and hypoallergenic. A favorite thing to bring in for our patients is soft toilet paper. Common comfort items. You might want a new pillow, blankets that you know are cozy and from home, but remember there should be no down or feathers. Clothes are a very individual thing as well. Some people prefer to just use the hospital gowns and pants. If you choose to bring your own, just make sure that it's loose-fitting, comfy, cozy garments with a button-down front or at least a V-neck so we can access catheters and lines and take care of your care. Again, it's a home away from home for a short period of time, but you want to make it feel cozy. You bring in your computers to keep in touch with family and friends, pictures to remind you that you'll be outside again, books, magazines, puzzles, and journeys. But remember not to bring valuables. Don't bring a lot of money, jewelry, rings. We ask people not to have nail polish on, and then dried flowers and live plants are not allowed on the unit. Now I'm going to hand you back to Sandy.
Thanks, Terry. So now I'm going to go through the hospital course as you're going through this process. So there's 2 parts. One is stem cell mobilization, and the other is the actual transplant. And most centers do both in the inpatient hospitalization, which is unlike myeloma. the bona fide sister disease, myeloma, where one may be done as an outpatient, i.e. the mobilization. But for AL patients, the recommendation is to do this, both of these parts in the hospital. The first part is to get the stem cells out. So much like the dog whisperer, we have stem cell whisperer as well. These are medicines to lure the stem cells to come out from the marrow into the blood. The medication we reach for is called Zarzio, also called Neupogen or G. There's a lot of names for it. And you get several days of this. Usually that's enough to get the stem cells to circulate in the blood, but if that's not enough, we can give another medication called Rizobel. And very, very, very rarely will we need to use chemotherapy to rev up the stem cells in order to collect them. What are the side effects to expect? The Zarzio or Neupogen, it can cause bone pain, it can cause some headache. Usually it's treated with Claritin and Tylenol and is treated very well with these medications. The Rizobel, if needed, can produce some diarrhea, and Imodium usually does the trick. There is a rare side effect of splenic rupture for AL patients, but we do watch patients very carefully. So if you have abdominal pain, that is something that's important to report to your nurse and to your doctor to make sure that they evaluate before that. Other things to expect, sometimes because of these medicines, patients may have some shortness of breath, some leg swelling, and low blood pressure as well. You'll be monitored for this while you're in the hospital, but if you find yourself having some worsening of these symptoms, make sure you mention it to your provider. Drugs that we typically recommend against is we recommend no aspirin, no Motrin, no Aleve, none of those agents, because they can't, one, affect your organs, impair them, and two, aspirin can make your blood thin, and we would not want that during this part of your treatment. The stem cell collection, well, first is a catheter that needs to be placed in order to gain access to the blood. This is usually called a Quinton catheter that's placed in the neck. The patient then sits next to the machine for what we call apheresis. That's when the machine takes out the blood, spins out the stem cells, and then puts the rest of the blood back into your body. This is not a painful procedure. Usually takes 1 day to collect the stem cells. And after all this is done, the catheter is then removed from the neck. Some side effects that people may have as they're on the machine, sometimes they may feel tired. There may be some volume shifts because the machine is obviously taking out, your blood and putting some of your blood back in. And if patients who have cardiac amyloidosis may feel short of breath or sometimes have drops in their blood pressure or have worsened leg swelling. So make sure you watch for that. Lastly, there may be some low calcium. There is a very mild anticoagulant that we give in order to keep the tubing from clotting, called citrate, and sometimes that can make the calcium low, which can produce some sensation of dizziness or numbness. And if you experience that, make sure that you report that to your nurse. Transplant timeline. So the Neupogen is usually given for 4 to 5 days, then 1 day for stem cell collection. Sometimes right after the collection, the melphalan could be given, or sometimes people wait a day afterwards to give the melphalan. Whatever day the melphalan is given, that's called day -2. The next day is a day of rest, and then the day after that is day 0, where the stem cells in frozen bags are wheeled to your bedside, they're thawed, and then they are hung like a blood transfusion and dripped back into your bloodstream. These stem cells have homing beacons, so they know to go back to your bone marrow to reestablish the marrow. And then days 1, 2, and 3, people don't really have a lot of symptoms. Days 4, 5, 6, people start to have symptoms, and the worst days are day +7 to day +10. And then after that, as your white count comes back, patients usually feel better, and most patients get discharged around day +14. This is a sample inpatient transplant calendar that we give outpatients. Like I talked about, day +7 and day +10 is really where the peak side effects are. During that period of time, your immune system is low, and that makes you susceptible to infection. At that time, preventative antibiotics are given, and if you have a fever through that, we take that very seriously and give you IV broad-spectrum antibiotics. And if we suspect that you have an infection, like if you have a cough or a runny nose, we may have to delay your transplant if there's a suspicion, because we don't want to do this while you're having an active infection, even if it's like a cold or a viral infection, because that can get you very sick. Like I talked about before, the melphalan can affect your gut, and that can lead to decreased appetite, mouth sores, nausea, vomiting, diarrhea. And specifically in amyloidosis patients, we look to see if there's any bleeding from the gut. So that's something that we keep in mind. Amyloidosis patients need a higher platelet level in order to prevent bleeding. And obviously we give very good supportive medications, anti-nausea medications, and acid reducers to prevent you from having these symptoms. Very commonly, patients feel fatigued. There could be low blood counts. You may need a transfusion. We also monitor the patient's cardiac status very closely, and oftentimes we would do cardiac monitoring during this time while you're in the hospital, just to make sure that you don't develop any abnormal heart rhythms, and just to keep a close eye on your volume status. Patients may become volume overloaded during this time. You're getting a lot of drugs, IV, and maybe IV hydration, and we do have to watch for that. Because of all this, there is a small, albeit present, mortality risk, around 3% within the first 100 days of doing the stem cell transplant. So these, the transplant course in the hospital as well as post-transplant, it's very important that we monitor you carefully to make sure you don't have any complications. In terms of the criteria for discharge, generally, Terry will go through this in more detail, but when you leave the hospital, the expectation is that you're not going to feel 100%, but that your energy and appetite will be around 20 to 30% of what it was when you came into the hospital. So as you can see, if you're not feeling well when you come into stem cell transplant, that we won't want to transplant you because we don't want to get you sicker. We'll hand this back over to Terry.
Thanks, Sandy. So I'm going to go through something, items that people frequently ask or things to think about after you go home. You're ready to go home. It's been a long haul, but you made it. Things, as Sandy said, that we need to have happen before you make that journey is your white count has to be greater than 1,000 with an absolute neutrophil of greater than 500. You have to be able to eat, drink fluids, and take your oral medications. And it's a good idea to get a medical alert bracelet so that it identifies you as a stem cell transplant patient. Set realistic goals for yourself. Remember, you're going to be excited to go home, but perhaps you'll be a little bit anxious. You will be responsible for your care. Up until now, we've taken charge, but once you're home, it's in your hands. You should expect to feel tired and a bit fatigued at times. Your appetite is going to be changed. You've been eating hospital food and little food at times. You might also have a change in taste from the different medications. So go slow. Eat mild foods at first and introduce new foods gradually, one at a time. You also might still be dealing with diarrhea or constipation. If any of those are occurring, please let your provider know so they can help you through that. You might need additional hydration or medications for GI issues. Insomnia is a frequent problem that we see. And again, we can offer medications if you need them. Weight challenges are always a problem for AL patients. And once you're home, we're going to put you back on a schedule of getting up in the morning, weighing yourself, and letting us know how you're doing. You're going to be given a appointment to see your outpatient hematologist before you walk out the door from the hospital. The date and time will be there. And important things to bring to that appointment will be a medication list and questions that you have for your provider. Make sure you keep a notebook or a journal with those questions listed. Sometimes once you're in the door with the provider, you forget everything you wanted to ask. Initially, we expect to see you 1 to 2 times per week, but the frequency of those visits will decrease as you get better. Remember, anytime you're coming back into the hospital, wear a mask and initially gloves. Be prepared for longer outpatient visits for medical needs as they arise. If your counts haven't fully recovered, you might need blood products. If you're dealing with diarrhea, you might need some additional hydration. Staying hydrated is very important. Remember, the signs of dehydration are feeling lightheaded with standing, being nauseous, or unsteady on your feet. Keep track of all your oral hydration, but not caffeinated beverages. They don't count. Your goal, once you're home, will be to have 2 liters of fluid every day. Before you actually leave the hospital, you want to have somebody clean your home. Again, it's not your job, and you should not be the person doing the cleaning. Get a service or have your caregiver help with this aspect. It's going to be a good spring cleaning, but the house will not be sterile. You shouldn't do recent renovations for 3 months prior and until your team says it's okay on the other end. Make sure floors are cleaned, walls, window shades. Pay special attention to the bathrooms, including the sinks, showers, tubs, toilets, and any areas that might be a site for mold or mildew. All your bed linen should be freshly cleaned when you get in back to the house, and they should be cleaned once a week once you're there. Buy new pillows. It's a nice time to treat yourself. Weekly, and again, maintain that weekly cleaning schedule once you're home. Don't use humidifiers because they're a good source of bacteria and mold. Everybody wants to have plants. It feels good, but limit exposures to plants and put them in rooms that you're not frequently in. Another thing that everybody misses when they're in the hospital are their pets. Cats and dogs are okay to have in the home, but just make sure they're up to date with their immunizations. And you should not be the one cleaning the kitty litter box or cleaning up after your dog. Try not to have them on your lap for prolonged periods of time. Don't let them lick your face or hands. And by all means, wash your hands after you're petting your pets. Other pets that people ask about and we discourage or don't handle or care for are birds, lizards, snakes, turtles, hamsters, or other rodents. All those can harbor bacteria. If you have an aquarium, don't do the cleaning yourself. It's nice to see family and visitors again now that you're on the outside, but remember you want to limit those visits to small groups. Make sure that nobody is sick when they come to see you. Colds, fevers, or even recent vaccinations with live viruses. Call your doctor immediately if you have any family member that has or has been exposed, or if you've been exposed to chickenpox, shingles, measles, or German measles. Again, everybody wants to jump right back in and resume everything they did before, but take your time. This is a process, and you want to listen to your body. When you're ready, you'll know. Typically, we recommend 2 to 4 months before returning to work or school. Start slow. In this recent time, we've been able to do a lot of remote working, and this might be an option for you. Start again slow. You can do 3 days a week or perhaps even half days, whatever your body tells you is okay. Remember, there's a time to adjust to getting back to regular activities. Your stamina and concentration will still not be 100%. Exercise is an important factor in you recovering from the transplant. Often you'll meet with a physical therapist and have a prescription to continue that at home. With that physical therapist, you'll regain strength and build stamina and balance. Expect to fatigue easily, and again, listen to your body. It's gonna tell you when you need to stop and rest. As you feel better, you can increase your exercise. Remember to stay away from sports with high risk for injury until your platelets are above 100 or your provider says it's okay. Now with the summer coming, if you did go home with a tunneled catheter, please refrain from swimming. Preventing infection is important. Your immune system has not fully recovered from the stealth stem cell transplant. It normally takes about 3 to 12 months for that immune system to fully recover. During this time, you're at risk for infection. I think most of you already know this, but signs of infection: temperature greater than 100.5 or 38, cough, flu-like symptoms, shortness of breath, sores in the mouth, burning or pain with urination, or diarrhea. If any of that should happen, please call your provider. It's important to reduce your risk of infection. Washing your hands is an important and probably the best way to reduce infection. You also want to shower or bathe every day. Avoid crowds and, by all means, sick people. Don't smoke tobacco or marijuana, and limit your sun exposure. If you are in the sun, you always use a sunblock of SPF 30 or more. We want you to stay away from gardening for now. Don't play in the dirt and plant your favorite flowers yet. Don't swim in public places, and don't get a manicure or pedicure in a nail salon. When you get home, treat yourself. Buy all new makeup. And again, if I didn't say it, washing your hands is the best way to prevent infections. Family and friends that come to visit should also be washing their hands. Platelets are another one of your blood cells that help your blood to clot and stop bleeding. Your platelets may not have been fully recovered when you were able to leave the hospital, but you want to watch for signs of bleeding and report them should they happen. Signs of bleeding are small red dots or petechiae, nosebleeds, gum bleeding, vaginal bleeding, blood in your urine or in your stool, and severe headaches. To reduce the risk of bleeding, use a soft toothbrush, no dental floss, use electric razors, and don't take aspirin or aspirin-containing medicines or non-steroidal inflammatory medications, including Advil, Motrin, or Aleve. Avoid activity with high risk for injury, and constipation can be a source as you're straining to move your bowels. Make sure you have adequate stool softeners and everything's moving smoothly. Nosebleeds may happen, and it's common to tilt your head back and try to stop the bleeding, but instead try to sit up and lean forward. It'll prevent the blood from flowing down your throat and causing nausea. If you can't stop it with light pressure, then add ice. If it still doesn't stop the bleeding, then please call your doctor. A common question, again, is sexual health. When will I feel back to normal? And when can my partner and I have sex? It's important to remember that you're going to feel different. It's an important time to stay open with your partner and make sure they understand your needs, and they can also discuss how they feel. You don't have to have intercourse to have an intimate relationship. Hugging, cuddling, gentle touching all help along the way. We don't want you to have any sexual activity that involves penetration until your platelet count is above 50,000 and your neutrophils are above 500. It's important to use latex condoms. And it's also important to use birth control so that you don't get pregnant. If you have any questions about this, please discuss it with your provider. There's also changes to your body once you're out of transplant. In women, there tends to be a change to menstrual periods, fewer or no periods at all. You may feel dryness in your vagina, and there are multiple moisturizers that you may use, but talk to your provider before you start anything. Men might have a decreased sexual desire or erectile dysfunction. There is treatment, and again, talk to your provider because we can provide either Viagra or Cialis at the right time. It's important to know that your immunity will be lost during the transplant, so you will be re-immunized with vaccinations. There's a routine schedule, and this, again, will be discussed with your provider. And they'll give you a schedule that they would like you to follow. In addition, the newest vaccine that we're seeing is COVID-19, and you will get a booster about 3 months after stem cell transplant. Again, discuss the vaccination process with your provider. In this slide, we see a standard vaccination schedule. It might be modified a little bit by individual providers, but this is some of the recommendations. At this time, you're a survivor. Congratulations. But don't forget about your routine health care. Continue to work with your primary care to make sure everything is up to date. You need regular eye visits, dental visits, an exam every year in which they'll look at your lipid panel, your BNP, NT-pro, and your blood pressure. Your kidneys are important, and we want to see how they're functioning. And we want you to keep up with vaccinations and secondary cancers that might occur. You want to stay up to date with your colonoscopies, mammograms, pap smears, and a PSA. Remember, it can be a long journey, but recovery is just around the bend. And now I think we're open for questions.
Thank you. That was a wonderful presentation, and just so many great tips, as well as just so interesting to hear the details of what happens and what patients will experience. And I loved at the start the recommendation to be shown what the stem cell transplant ward looks like. It's really disarming as a patient to be stuck in a room and not know what's beyond you. And when you ring a button for help, not to know who's there and how you're going to get help. We have quite a lot of questions that have come in, and I will read them out and hand them over to you. And if anybody wants to add questions, there's a Q&A box that you can just type your questions in, and then we'll get to as many as we can. And if time runs out, then we will make sure that these questions are answered and share the responses with you. So to start with, there's a question that's asking, is there a recommended age for a patient to have a transplant? And is there a maximum age?
So at our transplant center, we go by the biological age as opposed to the numerical age. Obviously, a patient who is young but has very advanced stage cardiac amyloidosis, be more difficult to get them through a stem cell transplant than someone who is older with like early stage renal involvement. So I think it really depends on how fit the patient is and what their biological age is, as opposed to a numerical age. The median age for this disease is around the 60s. So, most patients are in their 60s and sometimes 70s in getting these transplants.
And somebody asked a question, why is there different inpatient and outpatient recommendations for AL amyloidosis and myeloma?
I think I can speak to this, and Sandy can chime in certainly, but I think different centers do outpatient transplants and others just prefer or have the ability to keep patients inpatient. I don't know that there's a specific reason other than that's what the transplant centers do. Sandy, do you have any other?
Yeah, there's certainly some variability depending on transplant centers for myeloma-based transplants, but I think AL transplants, there is a higher risk because usually patients with the bona fide myeloma without AL, those patients have a very different constellation of symptoms. They usually have, for example, pain from bone lesions. They may have some renal dysfunction, anemia, high calcium. Those are typical kind of bona fide myeloma symptoms, whereas with AL patients, we're talking about patients who have of organ failure, right? They have organ dysfunction, cardiac dysfunction, etc. So these patients generally tend to be sicker going into stem cell transplant, one. And then two, I think the risks are different as well. Patients with cardiac amyloidosis, for example, I had pointed out in my slide, they are more susceptible to volume shifts, normal heart rhythms. So there needs to be special attention paid to them. When the patient's platelets go low during the course of stem cell transplant, In myeloma patients, we're not so worried about spontaneous gut bleeding. But in amyloidosis patients, we have to be careful and watch for that, make sure the platelet counts are not too low, to make sure that we prevent any spontaneous gut bleeding. So I just think that the disease profiles are very different to start with, and hence the risks are different. And I think that's why AL patients are almost uniformly really done as an inpatient, and myeloma patients can be done as a hybrid.
Thank you. There was also a couple of questions about staging. So what is cardiac stage 3? What is the upper limit of NT-proBNP? And also what's the, would kidney failure disqualify you?
Yeah, so there are several staging systems for cardiac amyloidosis. I think the first one really was from Dr. Dispensieri at the Mayo Clinic, where it stratifized patients into cardiac stage 1, 2, 3, and then Dr. Wishalaker in the UK further separated stage 3 patients into 3A and 3B. So that's a long-standing way to stage cardiac patients. More recently, Dr. Kumar at the Mayo Clinic has another staging system that takes into account the light chains. And then more recently at Boston University, Dr. Sancharawala and her group, there's another cardiac stage based upon BNP as opposed to traditionally NT-proBNP. So when we talk about cardiac staging, we're talking about what are the biomarkers that are present at diagnosis that help us determine the severity of cardiac organ involvement, and it gives us an idea in terms of a patient's prognosis and survival. So that's what I meant by when I say cardiac staging. And then there was a second part of that question. Sorry, what was the second part, Isabel?
So what is the upper limit for NT-proBNP? Is there a cutoff number?
Yeah, so NT-proBNP, so the staging system is based upon NT-proBNP and troponin. We use for troponin I at UCSF. And if you have one elevation, that gives you a stage 2. If you have elevation of both, that gives you a stage 3. And then 3A and B are separated with an NT-pro greater than 8,500. So that's kind of how you separate it. And the NT-pro is considered elevated if it's about 332. So those are the values.
Okay. So there was a question on what kind of food should I avoid post-transplant?
We recommend initially when you get out to go mild. Not spicy foods are going to bother you. There are initially neutropenic diets that you're going to, until your white cells are totally recovered. You want to keep your meats cooked well. All the fruit, we avoid fresh fruits and vegetables initially. Thick-skinned fruits can be used and enjoyed, but otherwise we try to stay away from that for at least the first 50 days.
Thank you. So there's a question about AL with smoldering multiple myeloma and no organ involvement except black eyes. What markers should be used when it's time for a transplant? I think that's quite a general question about how do I know when I should consider having a transplant. Yeah, so that's that's interesting that this particular patient has AL, but no organ involvement except for it seems like raccoon eyes, which is the bruising under the skin around the eyes. So that's concerning because that means that the amyloid has a propensity to deposit in the small vessels there, which means in other places, if left unchecked, it can deposit in other parts of the body. And I think it's really in terms of how well the patient has responded to the treatments that's already been given. Generally speaking, if the patient is in a complete response hematologically, one argues that you can just simply
that's an adequate level of shutdown of the factory, if you will. But the patient is, for example, in a partial response, a very partial response, then yes, transplant may need to be entertained. I think if it's a partial response, I think it's actually pretty clear. We know partial responses, the majority of patients, like, that's really not adequate enough of control of the factory. I think VGPR is a little bit more gray in terms of whether or not we should take these patients to stem cell transplant. But obviously, if there's any evidence of organ progression, even when the VGPR, one should consider whether or not stem cell transplant will be helpful. So I think it's very individualized to the individual patient, and it's hard to give kind of general recommendations, but I would definitely encourage this patient to take this up with their amyloid transplant doctor or amyloid doctor, because it's a very individualized assessment.
And are there any strategies for helping cope with fatigue?
Make sure that you're getting a good night's rest. That's a big one. During the day, if you need to take a nap, it's allowed, and you have this time to do that. And also, keeping up with exercise actually will help with fatigue. Don't over-exercise, but don't plop on the couch and just let the day pass by watching TV. Stay active. And then we will check your TSH and all your other levels to make sure that's not a contributing factor. Again, good sleep, keep on a good cycle for your day and night, and rest when you need it, but also exercise.
There are lots of questions about the role of Dara in as a treatment, and we won't be able to get to all of these, but I do think one that's interesting is, does Dara impair stem cell production? Somebody who was on the Andromeda trial and took 5 days to get enough stem cells and was wondering if that could have been impacted by the Dara.
That's a really interesting question. So we know, we borrow from what we know from the myeloma studies, where patients, got stem cell mobilization after being exposed to Dara. It doesn't seem to really affect the stem cell mobilization. I think, that's been shown in the myeloma literature. So we borrow from that. The thought is that, no, it doesn't really impair stem cell mobilization. But obviously that's hard to tease out, because the Dara in the Andromeda trial, if the patient was on that arm, was combined with Cytoxan, bortezomib, and steroids. And the Cytoxan, also known as cyclophosphamide, with continued exposure to that, definitely can impair stem cell mobilization. So, if you got that cocktail, it's kind of hard to, tease out, which contribution of which drug it is. But generally speaking, borrowing from the myeloma literature, it doesn't seem to be any issues with stem cell mobilization. That being said, if someone is being mobilized after being on Dara treatment, at our institution, we generally recommend a 1-month washout from the Dara before attempting stem cell mobilization. But I think, hopefully in the future, there'll be more data from the Andromeda trial to look, obviously, that we were stem cell mobilized during the course, to see how those patients did.
So one other question is on renal staging, and what would eliminate you being able to have a stem cell transplant as far as kidney involvement? Yeah.
So, patients who are on dialysis in select transplant centers, they will be eligible. It's really people who are, have a very low eGFR. So patients who are in stage 3 renal disease, that it may be tricky to, the subset of stage 3 patients, where it may be tricky for them to undergo stem cell transplant. So essentially, by Dr. Palladini's staging system, stage 3 patients need to be carefully selected.
So I think we have time for one last question, and there was one about the spleen, and is there any way to assess who would be predict the risk for their spleen involvement?
Yes, that's a really interesting question. So splenic involvement by amyloidosis is not that easily, picked up, one. And two, there's really no studies that show that, you can pick it up and then portend the risk of splenic rupture. The risk is low, but it's present. So as of right now, there's really, no way to really predict that risk. Splenic involvement can be very tricky to diagnose. Oftentimes, spleens may not be enlarged or may not look abnormal on imaging, or even if they're enlarged, may just be mildly enlarged. So it's very hard to kind of, tease out those that will have an adverse outcome versus those that will go through it fine.
Excellent. Well, we're now at the end of the hour, and there are many questions that we didn't get to. And if you'd be open to it, maybe we can share some of these and we can post the answers to those. I would really like to enormously thank you, Dr. Wong and Terry, for really an informative talk today. I think it's been really enlightening, and just clearly there are so many questions patients have that they need to hear answers to. Sharing this talk will be available online on the ARC website, and we'll do a summary of some of the key questions and comments that were asked. We also have the next webinar, which will be on ATTR wild type, will be given by Dr. Martha Grogan on 10th of June. So register for that. And again, thank you so much for your time. It was an excellent presentation.
Thank you for inviting us.
It was a lot of fun.
Thank you.